And there's never been a study that shows that people who get palliative care live less long. So the evidence tells us you live just as long with palliative care. It improves your quality of life. It treats your pain and shortness of breath. It supports your loved ones. So it does all these good things with no side effects, and you live just as long.
And now, from San Francisco and the UCSF Rosenman Institute, the Health Technology Podcast with your host, Christine Winoto.
It's late at night and you're sitting in a hospital room holding the hand of a loved one who's just been diagnosed with a serious illness. The doctor has explained the treatment options, but the weight of the diagnosis feels overwhelming. Questions swirl in your mind. How do we make the most of the time we have? How do we ensure they're comfortable, supported, and able to live well, even in the face of illness? This is where palliative care steps in, a field dedicated to improving the quality of life for patients and their families during some of life's most challenging moments. And few people understand this better than Dr. Steve Pantilat, a pioneer in palliative care and leading voice in redefining how we approach serious illness. As the founder of the palliative care program at UCSF, Steve has spent decades advocating for patient-centered care, focusing on symptoms, values, and emotional support. His work began during the AIDS crisis in San Francisco, where he saw firsthand the importance of honoring patients' wishes and providing compassionate care even when a cure was not possible. In this episode, Steve shared his journey from those early days to becoming a national leader in palliative care. We'll explore the challenges he's faced, the lessons he's learned, and his vision for a future where palliative care is an integral part of healthcare for everyone facing serious illness. Here's our conversation. Welcome, Steve. Thanks for joining.
Thank you, Christine. Great to be with you.
It's so great to have you. I'm so excited that you're joining our podcast today. I always like to start with our guests and tell them a little bit about their background on how they choose the path where they are today and what inspired them. And I thought I'd like to ask you that question.
It's interesting when I think about my path to palliative care, because when I was a medical student at UCSF in the mid-'80s, there was no palliative care at UCSF. In fact, there was really no palliative care as a field in the United States. But when I look at my path, what I realize is that I learned a lot about palliative care during the AIDS crisis. So I was here in San Francisco. I came here in 1985 when the AIDS crisis was really unfolding in a huge and very devastating way here in San Francisco. And I did my medical training here, my medical school and residency training here. And we took care of a lot of people with HIV and a lot of people with AIDS who were dying because we had no treatment. And so the question really was, how can we make sure that they do get the best care, even though we can't cure their illness? We didn't even have any treatments. Forget about cure. We didn't even have things to slow it down initially. And there were a lot of questions about decision-making for people and who is the right decision maker and how are we going to help them make decisions about whether to be in the ICU or to be mechanically ventilated. A lot of important questions for people who in San Francisco is a lot of gay men, a lot of people who had left their families and had partners, but their partner did not have legal status. And so the decision-making could be very complicated. And thinking about how can we honor their wishes and the people that are important in their lives, and how do we make all of that work? And that was a lot of learning for all of us together with patients and their partners. And when I look back, that's really was my introduction to palliative care. After that, I did my fellowship at UCSF in research, and then I joined the faculty and realized that that was the kind of care that I really liked. And I really was very interested in this idea of how do we make sure that people get the care they want, that they don't get the care they don't want. It was related to my interest in ethics and really trying to understand patient rights And particularly around, it was a time when we were really thinking about advanced directives and honoring patient wishes. There were some, major cases that had appeared before the courts. And so kind of pulling those things together, it was at that time that I also learned that there was a field called palliative care, that the thing I was interested in actually had a name. George Soros at the time, through the Open Society Institute, was funding a project called the Project on Death in America. And the goal, it had many goals, but one goal was through the faculty scholar program to create a cohort of doctors and nurses and social workers at medical schools, nursing schools across the country to promote this new area called palliative care. And I applied and received a 2-year career development award from them, from the Project on Death in America, and met all these other people around the country who were interested in something very similar. And it was an opportunity to just be connected with a cohort of people who are interested in this topic, who are doing this work. And it was during that 2-year time frame from 98 to 2000 that we launched our palliative care service at UCSF in 1999, making it among the first in California and across the country. Not the first, but kind of in the first wave. And that's been my career really ever since.
It's really interesting that I did not realize that the palliative care in UCSF is not here until like late 90. Now that when I think about it, I thought it's always been around. It's just people don't like to talk about it, but I thought it was really interesting.
Yeah.
And as a doctor, oftentimes people say, like, I want to care for a patient, I want to cure the patient, and being part of applying for Project on Death in America. The name doesn't sound like very appealing. And share with us about, like, why is this important? Why this work is so important in caring for patient and for patient.
You're right. I mean, it was interesting that they called it the Project on Death in America. I think they were trying to make the point that we're not going to shy away from what it is we're dealing with, that this is an experience that we all have. Like, this will happen to all of us. And if we ignore the experience, if we try to pretend that it doesn't happen, it doesn't make it better and it doesn't make it not happen. And if we shine a light on it and if we talk about it and if we focus on it, we have the opportunity to make that period of life better. And that's really what palliative care is focused on. I define it as medical care focused on improving the quality of life for people with serious illness. And I tell my patients, that I'm not the expert in heart disease or cancer or Parkinson's. I'm not that expert. I know about those things. I'm not the expert. I'm an expert in symptoms, pain, shortness of breath, fatigue, anxiety, depression. I'm an expert in helping you think about what are your values and goals? What are the things that matter the most to you? How do we understand treatments and the treatments that are most going to be helpful to you? And then how do we provide support, emotional, psychological, spiritual, practical support for you and your family as you go through this experience of illness? And that's the areas that we focus on to help improve your quality of life as you deal with serious illness. And then the other thing I tell people is, our job is to help you live as well as possible for as long as possible. And that really is how we think about it, that even in the face of serious illness, or especially in the face of serious illness, how can we help you live well so that that period of time is a time when you can have a good quality of life and do the things that are most important to you?
Mm-hmm. Mm-hmm. At what stage, when I guess, which part of the journey of the patient when they say that this is the time for this patient to talk to you?
Sometimes that is right at the day of diagnosis. For many people, getting a diagnosis of a life-limiting illness is just a shock. I think about it like, there you are in an airplane and you're watching the movie and you're, drinking your coffee and everything's good. And suddenly the plane drops 10,000 feet and you look out the window and there's an engine on fire. That's what it's like when the doctor says, you have cancer. This thing that we thought was a nerve problem, that's ALS. And suddenly your world is just turned upside down. And it's just shocking. And you think, I'm going to die. I think for many people, the need for support, the need for thinking about treatment, sometimes even symptoms can happen right at that moment. I think for most people, appropriately, the focus is then on, okay, what am I going to do about this? What's the plan for my cancer? What's the plan for my heart disease? What's the plan for my ALS? And that's right. As things get more serious, more difficult, it's really the time to think about connecting with a specialty palliative care team, like with our team of doctor, nurse, social worker, chaplain. As you're going through treatment can be very difficult for certain diseases. Like some chemotherapies are really hard. They cause symptoms. I think those people really do benefit from palliative care. I think someone who's diagnosed with Parkinson's disease, maybe not, because you can live for 20 years or more with Parkinson's disease. But I think as people begin to have more symptoms, as they are facing difficult decisions about treatment, and as they find themselves needing more support and becoming, more impacted by the illness, that's when they should think about palliative care. And if there's one message I think there's two really important messages about palliative care. One, almost all the people who come to see us always say, I wish I'd come sooner. So sometimes people are reluctant. Sometimes their doctors are reluctant to refer them. But once they show up, they say, I wish I had met you sooner. So that's one thing I would say. The other is that there really is evidence that palliative care not only improves quality of life, so we have many studies that demonstrate that. There are some studies, particularly for people with cancer, that show that people who get palliative care along with cancer care live longer, not shorter. And there's never been a study that shows that people who get palliative care live less long. So the evidence tells us you live just as long with palliative care. It improves your quality of life. It treats your pain and shortness of breath. It supports your loved ones. So it does all these good things with no side effects, and you live just as long.
It's interesting now, especially with cancer. There's a lot of people survive cancer.
Yes.
But yet, when they're diagnosed, it changed their life, even though they might live longer than 20 years ago.
Yes.
And oftentimes they don't think about palliative care because they think that, well, I'm in a remission. But then it changed their mental well-being as well. And I think also oftentimes me being non-familiar with palliative care, we always assume I only go to palliative care when I'm about to die.
A lot of people think that, and that's not wrong. We are helpful when people are near the end of life. So I think that's really true. And I would include hospice in that, as hospice being a kind of palliative care. It's a particular type of service generally provided at home for people with a 6-month prognosis or less. It can be very, very helpful for the patient and their family. So that's a great service as people are approaching the end of life. Certainly, we take care of people in the hospital and in the clinic who are approaching the end of life. We have a lot to offer people in those settings. And as you pointed out, we have a lot to offer people who are undergoing treatment, including curative intent treatment. In fact, there's been a study of people undergoing stem cell transplant for leukemia, curative stem cell transplant, who are randomly assigned to get palliative care or usual care in the hospital and then after they leave. And what they found is that the people who received palliative care had a better quality of life while they were in the hospital and for 6 months later in the setting where they were undergoing cure treatments, not just to manage the illness, but really to cure it. And to your point, A lot of people undergoing treatment have a lot of symptoms. They may have pain, nausea, fatigue, depression while they're going through treatment. And having another team, an extra layer of support while you're going through treatment can be exceedingly helpful for feeling better and having a better quality of life while you undergo treatment.
So do you think, is it not a standard till this day if you got certain diseases? It's like, hey, Christine, you're diagnosed with this. I want you to meet with Dr. Pantilat in the palliative care. Or does it more come from the patients to say, like, I'd like to see a palliative care? But most patients don't know about it.
Right. I wish it were standard that if you had X disease or X condition, you would be automatically referred to palliative care. That is not how it works. But that's mostly not how it works generally. Someone has to think about the referral to a specialist, and it's some combination of the doctor and the patient and the family who have to think about it. We do have close relationships with many of our colleagues at UCSF who are really great about referring. And it can be challenging at the same time. Palliative care can often have a different meaning to the patient and the doctor than a referral to a cardiologist or to a surgeon. Because there is this misperception that it means either things are not going well or they're not going to go well in the future. And that's why I'm referring to. So that it has a lot of potential, like emotional, kind of psychological meaning, maybe more than it is meant to have, which makes that conversation more difficult.
Mm-hmm. It's almost that we need a better marketing language for palliative care.
I don't disagree with that. And that's why we talk about quality of life. That's what we talk about. We talk about improving quality of life for people with serious illness. And that's why we focus on that, because that's where the evidence is that we really do have that impact. And our patients with serious illness, they're focused on living well. That's where their minds are at. Like, I want to live long and I want to live well. And we talk about, like, how can we support you in doing that? And that, that's how we talk about the work we do, because that is the work that we do.
Yeah. I think it's really important that, like you're saying, death is something that's part of life, that we all going to experience it one day.
Yes.
And I think having the right tool to embrace it or to understand it, hopefully make you look at it differently, I think. I still remember when I was a child, growing up, that when somebody got really terminally ill, like cancer at that time, the first reaction is always, oh, we cannot tell the patient.
Right.
And I definitely see things have changed tremendously. And I'm sure there's the evidence. In how do you kind of talk to the patient if you have a loved one who went through cancer, and to have that conversation about this palliative care without them thinking like, oh, you want to talk about death?
In many ways, in palliative care, what I talk to my patients about is, how are you feeling? How are your symptoms? We talk about, look, if you got sick in a way that you couldn't speak to the doctors and nurses directly, who do you trust to make decisions about your care? And what kind of decisions would you want them to make? And it's not that hard to imagine that any of us would just get sick in a way that we couldn't talk to the doctor. You don't have to be dying for that to be true. You just have to be sick. So it's not that hard to imagine that. And that's a really important question of who do you trust to make decisions for you? And then just asking, like, how are you emotionally? How's your mood? How's your family doing? How are your caregivers? Do you have enough help? I think the things that we're asking about are very tangible and very real for people who are dealing with serious illness. And so that conversation, I don't start a conversation by saying, hey, let's talk about death. I I understand that there there is an interest in kind of what will my death be like, and how can it be peaceful, and how can it be comfortable and dignified. And there's reasons to worry that it won't be those things, particularly in kind of modern healthcare, that you could end up getting a lot of treatments you don't want that may not really help you and may increase your suffering instead of reducing your suffering. So there's a lot of worry about that, which I appreciate and really do understand. But that's not where we start, mostly because there's so many more important things to talk about, particularly early when we meet with patients, and because that's not where our patients are at. If those of us who are healthy worry about what our end of life is like and think about that, and I think that's useful because recognizing that our time is limited reminds us to make the most of the time that we have. And I think a lot of spiritual traditions, a lot of religions have rituals and reminders that life is limited, and how you spend it, who you spend it with, what you do in your life really matters. Even if one day we live to be 150 or 200 years old, it's still limited. So what we do still matters every day. And I think that's really useful. And if thinking about death gets us there, I think that's really great. But what I see with my patients who are sick is they now know that they're not going to live forever. They know it in a tangible way, like we talked about earlier. They know it in a way that is very real. And they think about it all the time. Like once you have a serious diagnosis, you might forget it for a few minutes, but it's always with you. That's not the focus is really, okay, how am I going to beat this? How am I going to live long? How am I going to live well? How am I still going to do the things that matter to me? Can I still work? Can I still travel? Can I still enjoy my children? Can I still garden? Can I still knit, write, whatever it is that's important to them? That's where their focus is. And that's where we focus with them so that they do as well.
And I think that's a healthy way to focus instead of focusing on when I'm going to die, because that would be very depressing.
Yeah. And there are times when we talk about that as well, because people do worry, like, what is that going to look like? I think as people get sicker, that is on their minds. And we don't shy away from talking about that either. If someone asks me, Dr. Pantilat, how long do I have? We're going to have that conversation in a very real, kind, compassionate, but in a very real way, to talk about what the ranges might be. Are we talking days to weeks, weeks to months, months to years, a few years? Because people are going to plan around that. I had a patient in the intensive care unit who was very, very sick with a condition called interstitial lung disease, which is this chronic scarring of the lungs that has treatments but not a cure. And when she had it, there weren't even treatments for it. She was in the ICU with pneumonia, very, very sick on very high levels of oxygen that we could only deliver in the ICU. And I asked her a question that I ask all my patients, which is, when you look to the future, what do you hope will happen? To really understand, what's most important to you now? What are the things that are on your mind? And she said, I hope to see my daughter get married. And so we talked about that. And I said, tell me about that. And she said, well, she's getting married in 10 months in the Napa Valley. I said, okay, that's really important, but I have to say I'm really worried about that because you're very sick. And I don't know. I worry that you're not going to make it. And in my mind, I thought, I don't think, there's no way. But her daughter was there, and her daughter said, well, this is really important to me too. I'm just going to get married right here in the ICU. And sure enough, a few days later, her daughter came to the ICU in this beautiful white wedding gown, and her fiance had a tuxedo on, and they put a corsage, this beautiful corsage on my patient's hospital gown. Our chaplain from the palliative care team presided over the wedding. There was family and friends and nurses and respiratory therapists and doctors, not a dry eye in the ICU. And she got to experience the thing that was most important to her because we asked about it, because we didn't shy away from both asking what was important. And when she told us, we didn't just say, "Oh, yeah, I hope so too." And then she said, "Oh, I'm going to make it, but I'm thinking the opposite." I said, I'm worried about that. And if that's important, I think that's something we need to do soon. And yeah, it's not our ICU is not the Napa Valley. I mean, but it was a beautiful wedding. It was meaningful to everyone, and she got to experience the thing that was important. And y- those are the issues that we want to address of like, what's important to you? What matters to you? What are you worried about? What is it that people are worried about? They're worried about pain. They're worried about all sorts of things that we can address and we can talk about honestly. I can't always promise exactly how things are going to go because nobody knows that. But once we understand what's important and once we understand what you're worried about, we can really do our best to try and help you do the things that are most important and try to anticipate and minimize or eliminate the things that you're worried about.
Mm-hmm. Listening to your story make me think about what you said earlier about this palliative care is really to care for your patient.
Yes.
And actually, it sounds very rewarding to what you do.
I think it's incredibly rewarding work. So it really is very meaningful personally, and we can see the impact that it has on our patients. It's interesting, Christine, I used to practice primary care and hospital medicine as well. And whenever a patient sends a card, it's very meaningful and I always save them. But I always had more cards from palliative care patients and from the patients I cared for who were very sick and who died, because it's a very profound experience. And trying to make that experience less awful. It's awful when someone dies. It's so sad and is filled with grief and loss. We don't make it good, but we do our best to make it better than it would be if we weren't there.
Yeah. I think as a society, I've seen more and more conversation around grief. As you probably know, I lost my husband 11 years ago.
So
I have certain image about what grief is like. It turned out to be different from what I experienced. And again, we always look at movie as the way I was like, oh, that's how it works. But, of course, movie is only 2 hours and everything takes a long time. And do you think having more conversation about grief can be a beautiful thing? That's something that I found out about it. If you asked me 12 years ago, 15 years ago, are you crazy? How could you say grief is a beautiful thing? But I think it kind of deepened the relationship you have with the person that you love that I never knew that was possible. And so I always felt when somebody lost a loved one, it gives you a different life experience that allow you to reach in that you would not have had otherwise. And I'm sure you see a lot of that. But I like what you're saying that, we need to talk more about it, then people more aware of it. And I think sharing that experience allow you to create a different community that you would not have had.
Christine, just to the point of grief, it is such an important issue. And you'll sometimes hear people say, oh, don't worry, you'll get over it. And I think what we know is you never get over the loss of someone that you love.
Right.
It does get less painful. The grief does get less painful, but it never goes away. And I think you made a good observation, which is, the grief is in some ways a reflection of the depth of the relationship, and it can evolve into kind of a memory and a connection to someone, how they're always with you and how you hear their voice. One thing a colleague of mine once taught me that was very meaningful to me was to ask someone, how are you thinking about your loved one today? Like, how are you thinking about your wife? Not, are you thinking about them, right? So I wouldn't ask you, Christine, what are you thinking about are you thinking about your husband today? Of course you are. I think about him every day, probably, 100 times a day. And just acknowledging that, people are with us and really attending to grief. And that is something that we are learning to do better as a society. And I think part of this idea of talking about death as a part of life is also acknowledging grief. There's so many things that are hard about it, like the anniversary of someone's death that maybe your close friends and your family remember, but people don't. Like, we don't have a good way of remembering that in our society. And so these days where we feel so sad on the anniversary, no, people don't know, what we're going through. And there's an opportunity for us as a society to really be more open about all of this so that we can support each other, including through grief.
Yeah. And I think I learned also is that people oftentimes don't like to ask you about the person you lost because they are afraid that you get sad again. And I always tell everybody, a friend of mine just lost their husband 2 years ago. And it's like, oh, I don't want to mention him because I don't want you to feel sad. And so I mentioned to this person that our friend would love to hear a story about their husband because you don't have news story when somebody die. So to have a story coming from another person about their loved one, all of a sudden you get new material that you did not have. And so I always try to encourage to people to share their experience they have with somebody who passed away with their loved one, because that is something that they like to hold on to.
Yes.
And I don't want to talk a lot more about, so much more about grief. I can talk forever about this. And one of the things that there's a lot of lesson to be learned from death. I definitely learned a lot from it. And you've seen that, you help patients fulfill their dream before they passed away to make them feel better. What are the 3 things as a human being that you felt like, this is the 3 lessons that I need to remember as I go through life, through my journey to make me a better human being?
One is the things that we spend a lot of time worrying about are not usually the things that get us. And the things that get us are usually the things we didn't know to worry about. And so it just reminds me to just maybe worry a little bit less and have a little bit more, calm as I approach my life. So I think that's 1. 2, just how important it is to be intentional about the things that we do and kind of how we spend our time and who we spend our time with. And that, at the end of the day, it's really about our relationships that really matter the most, which is not to say work doesn't matter. I think a lot of people get tremendous satisfaction from their work. I certainly do. It is such an important part of my life. Mm-hmm. And I feel really proud and grateful for the opportunities that I've had to kind of impact the world through my work. And I'm aware that, when it's my time, it will be the relationships that really matter so much. So who we spend time with, how we spend that time is really important, and to be intentional about it. So I think that's another lesson. And maybe along with that, a related lesson is, to embrace the things that we want to do. It's funny. I sometimes hear, people talking about extreme longevity and wanting to live to be 150 or 200 years old. And people say, well, then I could learn to play the guitar and I could learn how to speak French. And I always think, like, are you learning to play the guitar today? Like, are you taking French lessons today? Because if you're not, there's no guarantee you'll live to be 150. When are you going to start? When you're 145? Like, it will always be limited. If that's why you want to live long, is so that there's something you want to do. Well, there's today for those things. Mm-hmm. And how do we really kind of embrace those those moments, those opportunities to do the things that really matter to us.
Yeah, I think that's a good reminder. And we all human being, we are
Literally
major procrastinator.
so much. Right. Because we think there's always going to be tomorrow. There's just another tomorrow and another tomorrow. And, and for most of us, that really is true.
Right.
And, taking a time to really think about, and it doesn't have to be big things. I mean, I talked about like learning French or playing the guitar. It could just be, spending time with the people you care about. It can just be like really enjoying the meal right in front of you, or whatever. It can be very simple things.
Yeah.
It doesn't have to be big, profound goals that people have.
Yeah. It's interesting that we always like everything to be big thing, which is great. But I think when, I learned this when my husband passed away, what you miss about a person is this little things in life, not the big vacation that you had in whatever, but it's more that little thing. And I just thought that, we pay so little attention to the little thing in life.
That's right.
And
a great poem by Marie Howe called What the Living Do, which I think makes his point so beautifully. And it's just like the mundane things about like, the sink is clogged and, walking down the street and brushing your hair and just these simple, and she's talking about, this is what the living do. It's in the moment. Yes. Mm-hmm.
It's definitely. And so interestingly, every time when now I pay more attention to this thing. And when I remember it was some famous person who passed away unexpectedly, and they interviewed somebody and they said the same thing. And what I found is really interesting that everybody can come from different culture, yet we're all human and we do something that's similar.
That's right.
So one last question.
Sure.
That I want to, we have a lot of people who are trying to make everybody's life better. And innovation is something that's always something that we care a lot. We believe that innovation can make a difference.
Yeah.
What are the things that you see in the palliative care innovation that you think that was a great, and what is still missing?
One innovation that has really helped us and our patients a lot is telemedicine, which is now, it's hard to call it an innovation anymore because it's become such an integral part of what we do. But boy, I remember when we started doing telemedicine visits, and we embraced it very early and very strongly in palliative care because our patients are sick and it's hard for them to come all the way to UCSF for their visits. So even before the pandemic, about half our visits were by video. And now it's about 97% because that's what our patients want. We always offer in-person visits, but that's what they want. And that innovation has really allowed us to reach more people, reach people who are farther away, and be able to continue to care for people who just cannot come as frequently to UCSF to be seen. And there's still more to be done in that regard of really understanding kind of what's gained and what's lost. And we've been doing research in that area to really understand what's the quality of care. So far, it really does appear that telemedicine in palliative care is as good. We recently participated in a randomized trial of in-person versus telemedicine palliative care, and it showed that they were equivalent. So that was good news to know that was true. So I think that's one area where we continue to innovate. And I think thinking about other ways to extend palliative care to more people and create more access. When I look out at the world and I think about what are the challenges that we're facing, it's that there are many people with serious illness who are not coming to palliative care. Part of it is that there's not enough palliative care specialists. And so we're really interested in innovating around how we can extend our team. And so we're doing a project now where we're looking at a set of orders that we use in the hospital for comfort care for people who are very close to the end of life to say, through those orders, can we improve their care without the palliative care team necessarily having to get involved? Is that a way to extend our expertise? And so we're examining that now. We have a project in group medical visits, which is not, that's been around for a long time, but applying it in palliative care and thinking about what are the right groups. Is it by disease? Is it, how should they be run? And some of our faculty are studying group medical visits as an innovation in palliative care. And I think another one is, for many people who are very sick, how can we care for people in their homes? There's obviously hospice care that happens at home, but how can we provide palliative care, and what does that look like? Who and how often do people need to go to the home versus by video visits, and really trying to innovate in that area. And then also innovating in other types of technologies that can help us to monitor patients, for example, to monitor pain and shortness of breath and anxiety, to target treatments for those symptoms and really understand how best to help people feel better. And then around caregiving is another huge area where I think there's a lot of opportunity for innovation of how we provide additional help in the home for people, which is something every one of our patients needs, is more care at home. But then also, how do we support caregivers, knowing what a difficult job that is, and can we innovate in ways that provide them with support, contact for questions, training. A lot of our patients have equipment. It's pretty complicated, ventilators and other kind of breathing machines and oxygen and suction, and just like a lot of equipment that makes quality of life better, but is something you have to learn. So how do we train people to use them and think about the innovative ways to get them the equipment they need, and then how to use it?
Mm-hmm. Yeah, it's definitely a lot more people wants to stay at home, but as a result, also it comes with a lot of other additional tasks, responsibility that used to be done by the provider in the hospital setting. But I know we are out of time. I really thank you for sharing your story and
thank you.
Your insight, as well as your experience with the patient and taking care of the patient and here at UCSF.
Thank you. Thanks a lot, Christine. It's great talking with you.
Thank you. Thank you for tuning into today's episode of the Health Technology Podcast. We hope you found the conversation insightful and inspiring. If you enjoyed this episode, please take a moment to subscribe, rate, and leave a review on your favorite podcast platform. Your feedback helps us continue bringing you the latest in health innovation. Stay connected with us on LinkedIn and Twitter for updates on upcoming episodes and more. Until next time, keep pushing the boundaries of what's possible in healthcare. I'm Christine Minato, and thank you for listening.